right, it says going live. Awesome. Thank you so much for joining us today. And my name is Sarah Ann Jank, and I work at the Arizona Statewide Independent Living Council. And this is our webinar series, the 2020 Partners in Preparedness Summit Series. Traditionally, this has just been a one-day in-person conference, and we have expanded upon that, unfortunately because of dire circumstances, because of the COVID-19 circumstance. But we have taken advantage of that and made these national conversations. So although we are in Arizona, and it'll have a little more focus naturally from us being in Arizona, we've brought speakers in that are from Arizona and from other places, and I'm looking forward to hearing their input. We are also streaming live, so anyone from the public and professionals can join us. I'm going to hand it over to two ladies who I just want to mention, both of them, Kelly and Kathy, because they have just volunteered extra time, their expertise and knowledge to working with me at AZ Silk on the Emergency Preparedness Committee, and have just been a huge help. And so I just want to commend them for doing this volunteer work, so thank you. And I'm going to hand it over to Kelly.
Hi, my name is Kelly Carpo, and I want to start by saying how uncomfortable I am on camera. So I am not in crisis. It may look if I am because I'm super uncomfortable, but I'm good. I wanted to talk a bit about the emergency operations plans and preparedness as far as inclusion and equity go. In my humble opinion, this document ensures that everyone gets a table and that everyone has a conversation. And it is from the beginning of the process and identify for planning team, at least for schools. I do most of my work in the schools around emergency operations planning and advocacy. I use the emergency operations plan because it is so inclusive. Everyone, like I said, gets a seat at the table. Everyone has a voice in the conversation. We may not all be involved throughout the entire process, but if everything goes as recommended by FEMA, then everyone's concerns will be addressed. So I'm really glad that we have someone here from DEMA, or who used to be from DEMA, and someone from U of A, and also Ms. Mathis from a federal level. I'm sorry, I suck at being on camera. I wanted to ask everyone to introduce themselves, starting with Jennifer.
Sure. Hi. I'm sorry I'm sitting in the dark. I'm going to turn on the light in a minute, but somebody turned it off on me. Jennifer Mathis, and I am the Director of Policy and Legal Advocacy at the Bazelon Center for Mental Health Law. We're a national nonprofit. We are based in Washington, D.C., and we do work both in litigation and policy advocacy, advocacy with Congress, advocacy with the administrative agencies, and a lot of kind of technical assistance and education work. And we do, primarily we represent people with psychiatric disabilities. We also sometimes represent people with intellectual and developmental disabilities. And we've been around for, 45 years now. We are focused primarily on community integration issues, but really all sort of civil rights and inclusion and self-determination are kind of our focus.
Awesome, thank you. And Ms. Whitney?
Hi, thank you, Kelly. Good afternoon. I appreciate the invite for being here. My name is Whitney Hinziak, and I'm with Crisis Response Network. I'm the manager of experience and engagement there. One of my roles at CRN is truly telling our story, getting involved with stakeholders, partnerships, coalitions, and continuing to tell what we do, how we do it, how our resources are accessible, and so on and so forth. I appreciate, again, Sarah Ann, the invite. I am all familiar with the Partners in Preparedness Conference. I remember the first one and having been involved with it ever since. And yes, it did used to be in person, but I'm coming to you from my dining room. So that's okay, as long as we can get the information out. I don't know that it matters how we do it. So happy to be here and happy to always help out. Thanks, Sarah Ann.
Thank you. And Dr. Emmerich?
Hi, I am Dr. Catherine Emmerich. I'm an outpatient psychiatrist in Tucson, Arizona. I'm actually in my office today, although we don't have a lot of patients in the clinic. So I do outpatient clinical work, but I'm also on faculty at University of Arizona. So I also work in teaching residents, and I'm also the interim outpatient medical director. Feel a little bit like the odd man out because I think it sounds like I'm the only one that's not directly involved in advocacy work, but we have a really wide patient population that we work with, and we work really hard to promote inclusivity in our clinic.
Thank you. And I believe the first question was going to be for Jennifer. Kathy, if you want to take over from here with that.
Okay, what I was hoping is that Jennifer could talk first, and I was going to ask some questions. I know so we also have some questions posted, but I think what I would like to share is that our community has been very active with the recent emergency, and we've done a lot of research, and maybe Jennifer can respond to this, but in many cases, because of social disparities, from testing to getting treatment, inclusion, having, knowing our community and what the needs are, we've been left out. And we've had to be very active in writing letters. But I guess my question, and I hope, Jennifer, you can kind of address this, is, how could we as a community be more effective, the whole disability community, be more effective in the long run, and because this took us so much by surprise. And so I'll turn it over to Jennifer, and if you could address that and whatever you're going to be speaking about.
Sure. Well, I mean, that's a great question, and it's a big question about, I think, overall how the disability community can be most effective. I mean, I guess I would say that with respect to, the particular crises that we are facing now around COVID, and all of the different ways in which, I mean, as you say, we've sort of been locked out. I think of this in sort of several different buckets. I think all of these are things that there's really a need for kind of coalition work. Certainly, I mean, our strength in the disability community has always been in numbers, and it's always been kind of working across the entire community, collaboratively. This is hard, because especially in these kind of crisis situations, but I will talk a little bit about some of the work that we have done, and I think that is applicable, in Arizona as well, and some of the ways in which, some of it's been effective, some of it we have yet to see, but, certainly one of the first things that jumped out to us was that, there was suddenly potentially going to be issues around who gets life-saving treatment and who doesn't, right? And so, you have these rationing schemes for COVID-19 treatment, which in some cases were on the books already, and from H1N1 a number of years ago, and in other cases, was being updated from that in some states. Some states didn't have any rationing policies and started to develop them, but we started to see more and more, a trend toward having some kind of rationing policy, rationing scheme about treatment in the event that, as people were expecting, maybe we wouldn't have enough ICU beds, maybe we wouldn't have enough ventilators, and who was going to get it, who wasn't, if there weren't enough, right? And so, it was pretty clear, I think, as the initial press reports came out, the first policies that we became aware of were in Washington State. There were a bunch of articles about that, and then Alabama and Utah and a number of other states followed. And so a number of us across a bunch of national groups, the ARC, the Bazelon Center, Center for Public Representation, in the case of Washington, it was the Washington Protection and Advocacy System, Disability Rights Washington, and Sam Bagenstos, who's a law professor / advocate, mobilized, and actually an autistic self-advocacy network, I think, was involved also, and mobilized and quickly, like over a weekend, filed a complaint with HHS Office of Civil Rights saying, we think that these policies, this rationing scheme, discriminates against people with disabilities because for example, I think in Washington, some of the issues were triage teams were supposed to consider whether you have a quote unquote loss of reserves in energy, physical ability, cognition, and general health. That might send you to palliative care instead of getting treatment. Prioritizing healthy long-term survival, weighting survival of young, otherwise healthy patients more heavily than older, chronically debilitated patients, quote unquote. In Alabama, there were rationing policies that said if you have quote unquote severe or profound mental retardation, they hadn't changed the language to intellectual disability because this was an old policy, then you were not a good candidate for a ventilator. Okay, and so sort of categorical exclusions based on diagnoses. There were values about or value judgments about quality of life experienced by people with disabilities that we knew were not accurate. There were factors of sort of long-term survivability that really had nothing to do with whether or not you could survive the COVID treatment. It was more about, even if you can survive the COVID treatment, you might not get it anyway because, we think that you have some condition that in the medical profession, we're kind of guessing that maybe you won't live 10 years or something. And so that sort of assumptions about long-term lifespan, life expectancy, the resource intensity, if you might need to be on a ventilator for a little bit longer because of a disability, that would put you down further on the list or in some cases exclude you. And so all of those considerations seem to us disability discrimination. But I think that, it was very helpful to mobilize a campaign with lots of different folks. We had a number of folks on the national level. We were coordinating with folks in a number of states. My understanding is that, there's a group of folks, some of you may be included in Arizona who are also engaged in this discussion, and there has been a lot of back and forth. What that advocacy produced, and we had some conversations directly with HHS OCR to talk to them about our view of the law and what the ADA requires. And, we knew that I think there was some willingness there to listen. There was an interest in this particular set of issues. And so, sure enough, we got some guidance from HHS saying that it is discrimination, it does violate 504 and the Affordable Care Act's non-discrimination requirement to discriminate in for example, singling out people based on diagnosis, and it has to be an individualized assessment, making judgments about the value of the quality of life or the value of a life with a disability, and some other helpful statements. And so I think the more that we ended up filing some complaints in cases where people couldn't work something out with the state, the more the HHS started to resolve these complaints. And we now have several resolutions from the federal government that make clear the parameters of the law. I think so. Most recently from Tennessee, we had HHS engaging in a resolution with Tennessee where Tennessee made changes such as, in order to satisfy HHS that they were not discriminating based on disability, they had to clarify that resource intensity and duration of need on the basis of disability cannot be used as criteria for whether somebody gets life-saving treatment. Clarified that a patient's long-term life expectancy cannot be a factor in allocating scarce medical resources. Clarified that you have to make reasonable modifications to the instrument that they use to determine actually short-term life expectancy, because there's some pieces of it that discriminate based on disability for people with certain underlying conditions. It's going to measure disability rather than somebody's likelihood of surviving the treatment. And it also made them remove categorical exclusions based on diagnosis or disability. And it also said that Tennessee had to remove provisions that would reallocate people's personal ventilators that they used on a long-term basis if they went into an acute care facility. So they might lose their vent that they've been using, for years, because it would go to somebody else who might be considered higher priority. So I think those things were very effective. How did we do that? I mean, that was all, I think, a lot of people working together. It was a lot of different heads, and it was sort of a nationwide effort. I know it hasn't been resolved in Arizona, but I know that's very much on the table, and I think that there are ways to resolve it, and I'd be happy to talk, offline with people about that. But I know there are folks from our group who are talking to folks in Arizona about it, and so, I mean, I think those things are just critically important, and I think there is, a federal agency right now that is very, very interested in those issues and invested, and has said, a lot of very important and helpful things for people with disabilities about what the law is. And so I think, that is one area where I think people can be effective. You can create change. We've seen it now in so many different states, and it doesn't get a whole lot more important than that, who lives and who dies, right? And I think we're all expecting potentially, another surge, and I guess you guys have a surge already that is still happening. And so, this is imminent. And so I do think that this is an area that is worth spending time on, and there is the potential to be effective. It's sort of, do the stars align? I do think you have an agency that's willing to listen and that's willing to act, all right? And you do have a coalition of players. I think you have a pretty good coalition in Arizona working on this. So this is one area where I think you can be effective. Another area where I think it's hard, institutionalization. We know that, right, so many people with disabilities have been dying in institutions, whether it's in nursing homes or psychiatric hospitals or ICFDDs, intermediate care facilities for people with intellectual and developmental disabilities. And I think that has been a huge tragedy. It's kind of revealed all the weaknesses of sort of our systems that rely so heavily on institutional settings. And, I think that many of us have been concerned that these are civil rights violations of Olmstead and the ADA's integration mandate. But now you have something beyond that too, right? You have death traps in many cases. And so and we've been involved in some litigation in Connecticut. There is litigation happening in Washington, D.C. that we're not involved in. Sometimes you have to bring lawsuits. I don't know what will happen, but we felt this was enough of an emergency. And there were 5 people who died in the Connecticut hospitals where we had brought those cases actually after the litigation was brought. Whether we win or not, a lot of changes have been made because of that litigation already, right? And so that is pretty important. Yes? Yes?
Okay, so what you're sharing is greatly important, and I'm a little worried because you have to leave at 2:30, and so I wanted to get one little piece in.
Yep.
What you've done, your work is absolutely amazing. What I'd like to share is that I spent 7 years in mental hospitals, including the Arizona State Hospital, and with that in mind, quite a number of people have called me, and there's some questions that people would like to directly ask you about the Arizona Supreme Court proposed amended definition of mental illness, and that is to expand the definition to include substance abuse, DD, people with DD, and this isn't a standalone. This means a person with DD could be considered as having a serious mental illness. But the implications for that are very great because they are also expanding the use of forced treatment. And so we would like to have further conversations with you on this. We've tried to reach the Bazelon Center to make some comments.
I'm sorry, we probably haven't gotten far because we've shrunk so much that, you know, we get so many questions, individual questions from people all over the country every day that mostly we don't answer because we wouldn't do anything else if we did. But now that you've raised this, I am happy to engage. So yeah, definitely.
So Sarah's going to set up an appointment with you and members of our community to further this discussion.
Okay.
Thank you, Jennifer.
Sure. And I've got a couple more minutes if you want to.
Okay, I'm sorry.
No, it's all good. I just got like a little tiny window here. So yeah, I can stay for a couple minutes longer. I can either answer those questions or I can say a little bit more, but it sounds like that might be better to have as a separate conversation. I'm happy to set something up maybe next week or something, if that time frame makes sense for that. Okay.
Yes.
That's great. And so I guess, just in terms of other things to think about, I mean, I think that institutionalization issue, the most important thing that people do need to be thinking about is how do you get people out? I mean, people have talked a lot about, home and community-based services, and we need to expand those and all of that, and that's great, and that's true, and that's important, and that will help, I think, divert new people from coming in the doors. But the reality is that, I mean, so many of those deaths happen because it isn't possible to do 6-foot distancing in, dining areas, often in sleeping areas. People's beds are often not 6 feet apart. They go in elevators. They're sitting in the dining hall, and, distancing is a falsehood in those settings. And so, one of the things that we've been seeking in Connecticut, I know that they're seeking in Washington, D.C. also, is sort of emergency discharges. What can we do? And it is hard because, yes, I understand the community service system has in large part, shut down for a while. It is just kind of trying to get back up. They're doing, telehealth now. A lot of restrictions have been lifted, but it's taken a lot of work to get things going. I do think that there are things happening in certain states that are good, that are better, good practices. North Carolina is a place to look, where I think they have actually been doing some good work. They are starting to do this in New York. I mean, getting phones into the institutions so community providers can engage with people, can talk to them. Doesn't work for everybody, but some of that really needs to happen. Can people be more flexible about, sort of the service planning for discharge? I mean, families might be an option where they wouldn't have been an option before. Not that you should send somebody to an inappropriate placement with a family, but can you build in extra supports for a family to have someone come back at least on a temporary basis? Can you consider other things? Can you do things with the providers that will incentivize people to take folks that otherwise would not have worked out? Can you support a placement that otherwise you wouldn't have done? And there are, I think, a lot of creative things that people can do to facilitate those discharges. And so that I just think is probably the most important issue. And so just wanted to raise that before going.
Thank you so much, Jennifer. And it looks like we lost one of our moderators, so I just wanted to let you know that and hand it back to Kelly.
You're on mute, I think.
Well, I'm glad nobody could hear me talking over anybody else. My question for you, with COVID-19, have there been changes or modifications to HIPAA or FERPA laws?
I think that there haven't been changes to the laws, But what has happened is I think CMS has, federal Medicaid has modified how they will enforce HIPAA in light of, I think, promoting telehealth. And, there were certain HIPAA concerns around sort of like Zoom use, or I think they've worked out business associate agreements, whatever they need to have. But there are certain platforms, I think, where, you couldn't easily do telehealth generally before because of HIPAA concerns, where at least for purposes of during the pandemic, CMS has said we're not going to go after people. We're not going to enforce HIPAA in those circumstances. And so I think that's the major change. And then at the state level, I don't know what Arizona has done, but mostly there have been a lot of state level restrictions that have been lifted in order to facilitate telehealth. And CMS has been more flexible about, how people can bill for services because of that as well. And will, not require face-to-face contacts in many cases where that can't happen, but will allow either a video conference to be sufficient, or in some cases audio. So.
Okay, and do you know about FERPA at all? Is that intact or?
Yeah, I don't think that, I'm not aware of changes to FERPA. I mean, certainly there hasn't been any legislative change, I think, in the federal packages that went through. There may be, certainly there's a lot of stuff that is going to happen when schools reopen. I think that is going to raise a lot of privacy concerns, and I'm actually part of a coalition that's going to put out some principles. We're working on them now to try to help guide things to say, yes, we understand that there will be certain data collection that may need to happen to make sure that, people aren't coming in and spreading disease if schools are reopening, but at the same time, that needs to be narrow and it needs to be careful, and people shouldn't be asking for broad information that's really much more than they need to know, and they shouldn't be asking for disability information. If it's a concern about somebody needing accommodations, then that person can ask, but you don't need to sort of make assumptions or make broad inquiries of everybody to try to figure out who might need an accommodation. That's their right to ask for one. So anyway, I think those are important issues, but I don't think there's been a change to FERPA as far as I know. And again, it may be, an enforcement issue about sort of how the law is going to be enforced by the feds, but
that makes sense. So when you develop those principles, how could we get them?
I have Sarah's email, and I am happy to share them with her when we send them out.
Okay, awesome. Thank you.
Sure.
And is there anything else you wanted to add before you have to go?
I guess I would just say that I think in my mind anyway, the two kind of real crisis issues, there's many with this pandemic: accessible testing and hospital no visitor policy, accommodations, and all kinds of things that have come up. But in my mind, sort of the two most significant things in general probably are fixing those crisis standards of care and doing something about really not just hospital admissions or nursing home admissions, on the front end, but really trying to focus some energy on, some people have called it emergency deinstitutionalization, emergency discharge, but, having a different eye than we usually do to kind of getting people out, because it's critical that people not die, and, it would not only, I think, keep many people more safe in the community, but would also enable the census to be reduced for anybody remaining in the institutional setting so that you could do distancing. And I think there is too often a sense, I have heard it from so many places, kind of an assumption that because people have these disabilities that they're going to be unsafe in the community, and we can't release them, that the safest place for them is the institution, despite what is happening with, all of the 40+% of the deaths nationwide are people in institutional settings. So that's pretty concerning. And to say that, no, people will be safer in those institutions than they are in the community seems wrong to us. And so I think that, that is a big hurdle to overcome. But I think, that is an important one to push on. And it's not an easy push, but I think people really need to focus on that. So that's it.
Thank you. I appreciate it.
Absolutely. All right. Happy to be here. And I will follow up. We can set up an appointment for next week. Okay.
Okay. Thank you.
Thank you.
Thank you, Jennifer. That was great.
All right. Moving right along. Whitney, can you tell us a little bit more about the COVID crisis line and what someone might expect if they called?
Absolutely. And there's variations thereof. Again, thanks for having me. Crisis Response Network, we have several different services we offer, resources, lines, all mostly inbound. For today's purposes, what we really started off doing as far as COVID response is concerned is the governor reached out and said, we need a COVID hotline, knowing that CRN is equipped heavily with inbound lines, being the crisis line, the warm line, and everything else that we have. We said, certainly, how do we want to go about this? Well, we also manage our state's 211 line. So people can simply dial 211 or go to 211arizona.org to find out all they need to find out about COVID-19, speak to somebody live about COVID-19 as a hotline. And the good news is, as of 1 July, 211 being live has gone to 24/7 service. That's for anyone, everyone, 24 hours a day, 7 days a week, at least for the next year or so. Just wanted to let you know that. So that's good news. And the other thing that we are doing as far as COVID response is concerned, I know Sarah Ann really wanted me to touch on this today. Also, what got launched and went live on 1 July was the crisis counseling program that opened up with FEMA. Opened that up as part of a declaration. A lot of states got this. I believe it was a blanket declaration among states. I'm not positive how far reaching that was. But the crisis counseling program went from FEMA to SAMHSA down to Axis here in Arizona. They needed an administration entity in Arizona to take this on and to manage it. Axis reached to us at Crisis Response Network. And we said, absolutely, we will happy to be the administrators and management of that program that comes all the way down from FEMA. So we reached out to providers throughout the state. We really are a pass-through to help manage this, but we do have providers in place throughout all of Arizona by region. And all people have to do to reach this particular program and to get help is dial 211. And that's the beauty of it, and that's the ease of it. So someone can simply either go to resilientarizona.org, and I can send links to Sarah Ann. That is the website for the crisis counseling program here in Arizona, and we're looking at this to be at least for the next 9 months. It is time limited as far as a declaration is concerned from the federal level, because it is federally funded. But when somebody calls, and anybody, and I mean anybody and everybody can call, it is free and confidential, and they simply say where they are, and they can get directed to a provider near them in their area. So we have providers participating statewide that we have asked, hey, can you help us manage and be part of this program and actually provide these services for the folks who are calling in. It is COVID related because as we know, as the pandemic started, all of us are impacted in some shape or form. I am not unfamiliar with the disaster world. I came from state emergency management prior to this great partner that is Crisis Response Network, who I worked with for years as a partner. People are impacted in many different ways from many different hazards. And this is one outlet for people to call and have someone to talk to beyond other services and resources that are out there that is COVID specific. And let's see, then also with that, we have been contracted as far as COVID response is concerned. We've also been contracted with Maricopa County Department of Public Health to help handle the contact tracing for Maricopa County Department of Public Health. So all being said, we are busy. Not unlike anybody else on this line or other entities that are watching today. I'm sure I have some emergency management friends out there in the audience. I feel for you. I have a feeling I might know intimately probably what you're going through in the last few months. So hats off to you and thank you for all you do, all of my friends out there who are watching. It's critical and everyone is impacted at a different level with their families. You may have someone who's not used to having kids at home. You may have families that domestic violence may have increased due to COVID and being at home. Substance use may have increased. We've gotten a little more calls on our crisis line, more about anxiety, depression because of this. So one thing I really want to get across today and emphasize is there are resources out there. It's a matter of getting people in touch with those resources. And I can certainly give our websites and our phone numbers, our crisis lines, but if anybody remembers anything from today, it's 211. It's a great way to access the COVID hotline, and it's the best way to access the crisis counseling program.
Thank you. I had a follow-up to that.
Please.
So with the Resilient Arizona and that hotline, now is that more of a referral source? Are people able to just ask general questions? Or would they have to do what kind of process before they got to speak with someone?
They'll get put to where they'll say, I live here, and they'll get put to that provider in that area. Then that conversation becomes confidential with the provider. I'm not sure then how the provider will manage that conversation. But I know they're going to be looking at it from the difference between mental health and crisis counseling being that kind of first go-to of prevention and resilience prior to anything that is of a diagnosis per se versus actual mental health help and services that go beyond that. So simply it's a matter of calling the 211 line and they'll get directed to someone in their area that's close by so they can talk to.
Okay, thanks. So
I have a question.
Sorry, Kathy.
This is Kathy. I'm not leaving you alone. This is Kathy. I'm president of the Arizona Parent Family Coalition, and we did a survey when the crisis first hit, and then we followed up about 3 weeks later. And we were surveying parent family members in the behavioral health system. And what we found is that the number one thing, people were very fearful. 2, they felt very alone. But 3, they could not reach their clinics. And so I think things are slowly changing. We've done a second, third survey, and things definitely were improving. But, you know, I live up in a rural area on Mingus Mountain in the middle of the National Forest. And, you know, I'm very, very socially isolated. And, you know, this has continued. And I have the resources to deal with it. But, you know, we as a community have tried to reach out to many peers and just have conversations with them because a lot of the peer runs are closed. They've identified the most high risk, and those people they've done reached out and done some services with, but we've still missed a lot of our people. And so has anything been done to fill this gap? And are you aware of some of these challenges? And by the way, I think you guys have done a fantastic job. You know, you really rose to meet, you know, the crisis, and it can't all be done in just, you know, overnight. I realize that, but we still have a lot of ways to go.
Right. What I can do is, Kathy, I'm not a clinician and I don't know enough about the topic area that you're asking about, but especially considering if someone can't reach someone that they're used to reaching, certainly any of our lines are available. And we do have our unique crisis line as well for Northern Arizona in your area. Yavapai County where you are. And then of course, 211 is statewide in case, and 211 is beyond COVID. And I want to be able to kind of touch on this a little bit. 211 is beyond COVID. It's also many other additional resources if someone may have something that may pop up because they may be impacted by this. It may be someone might need a food box, someone might need utility assistance, utility payment assistance, something like that, housing questions. And that's the beauty of that particular resource, to maybe get through some of those gaps. But if I may, Kathy, I would love to give you my email if you would like to email me, and I can put that to some of the clinicians and some of the licensed folks at our organization to see if they're hearing anything from that audience, and get back to you.
Okay, and to give you an example, and it's not just this audience, where I live, the closest neighbor is a couple of miles, okay? There's a lot of people that are up here that don't have transportation, don't have money. There's no way to order groceries from the grocery store because they don't have computers. So it's up to a small community to take care of them. The community has not done that. And so we've got pockets of people that are very isolated, that don't know how to reach out. Their only way to communicate is through the radio. I mean, they can't communicate, but that's how they get information.
Yeah, I certainly understand. We often, even back in the emergency management arena, we often know that those folks are out there, and especially even local emergency management, the county level or local, knowing that those people are there is half of it. And getting them in touch even with emergency management at that, so they know they're there. Because there are a lot of organizations locally within the county who maybe could help, knowing that they're there, and they might not know they're there. It could be through emergency management that they find out. It would be a recommendation of mine, and then we'll find out some of that other stuff for you too. Do they have?
Okay, and if you could send me your email.
Pardon me?
So go ahead.
You need my email?
I'm sorry. I'm on a satellite phone, so
okay.
I'm a few seconds behind you.
You are.
So go ahead with your comment.
Oh, I was just gonna say, we can certainly address some of those other things offline too, and get you more information, because we definitely want to make sure folks in those rural areas have a touch point, because I just know from experience it's hard, and transportation is always an issue that is a tough gap to fill.
Yes. Dr. Emmerich, what are you doing in your practice and through the university as far as community resources go? I saw that you had something. I thought that was really practical and user friendly.
Are you talking about the little handout I made?
I don't know if it was on a handout. I saw it online though. It was coping. And
so when it started to become really clear in about March that this was going to be a really stressful and traumatic time for people, our program started trying to figure out how can psychiatry be helpful in the community, to the people that we're serving, and also to our colleagues who are frontline workers. So the first thing that we did was I developed a kind of coping strategies handout that we published with some really practical tips on how you can kind of support yourself in terms of reducing your vulnerability to stress and to anxiety, as well as how can you kind of protect your mind and body, and what are some kind of hands-on ways that you can help yourself if you do end up feeling really anxious and really stressed, as well as kind of normalizing that when things are really uncertain and we really don't know what's going to happen, it's very normal to feel anxious, and there's nothing wrong or nothing unusual about that. The next thing that we did was our program started some support groups that were ongoing kind of at the beginning of the pandemic, where we worked with ED residents and faculty, and then also through the diversity and inclusion component of Banner to provide some support to LGBTQ identifying people. And then I also have been working kind of daily in my practice providing teleservices to our patients. So our clinic has pretty much completely transitioned into teleservices. And so we've been able to continue seeing our outpatient clinics, and we've also been able to continue doing intakes, meaning seeing people that need to be established with providers. And the benefit for us of doing teleservices is that we are able to see patients that are unable to travel, unable to find transportation, or who are ill. And that's actually been something that's been really useful, and we have found it to be something that we're really hoping to continue as a way to really get psychiatric care to the broadest population. And then kind of the most recent thing that I've been doing is that I've been part of the palliative teams on the inpatient hospital side. So working with patients and families of terminally ill patients, including terminally ill COVID patients. So that's sort of a broad overview of kind of what I've been doing in terms of the pandemic response.
I think that you guys are doing
So
great.
Dr. Emmerich, this is Kathy. This is Kathy. In the behavioral health community, recovery is really surrounded around personal relationships. And as we watch the response to COVID and the use of telemedicine, it makes sense right now. It's cost effective, and it really has served as a vehicle to outreach our community. Our concern as we move forward that people are not going to want to go back. And, you know, this is so important to our community at large. In the rural areas, it's fantastic because, you know, a lot of the no-show rate and everything, plus with CMS relaxing their restrictions. So at some point, we're going to have a conversation about the use of telemed, CMS restrictions, and of course with access to determine, you know, what a better balance. Can you make a comment on that?
Well, I guess I'm curious about what you mean by a better balance.
Well, right now, all you have really in the rural areas, and what you're saying is you're using telemedicine a lot, okay? Because that's what works.
And that's what we have available.
You know, there's a lot of providers, a lot of people are concerned that we're going to forget about that personal relationship, and because it's cost effective, continue with telemedicine without having those conversations about really what is most feasible and best for our community once we start to get over this pandemic.
I see. So how do we figure out how to balance sort of the benefits of telepsychiatry or teleservices with the benefits of seeing someone face to face and really being in community? Yeah, and I think that's
yes, because a lot of our population, especially people that have psychotic disorders, did not want to use telemedicine, and all of a sudden they're finding this is perfect, and they're really that's what they want to do. The show rate, you know, they're not having the no-show rate like they were. They're more engaged. So
and I don't think we've ever really seen teleservices on this scale before. So we are sort of in unprecedented waters of people getting a chance to experience it. And there is evidence that we are able to build really good relationships through telepsychiatry. And I'm not sure what all other groups are doing, but we've been able to maintain our group therapy through the teleservice platform and have been really successful with that, including in terms of patient responses. There are still going to be patients and situations and sort of experiences that will only really translate into being in person. I think we're going to all have to have kind of a big conversation about that going forward. But I think that there are some kind of common situations where people would agree it's really going to be better to be in person. So things like patients that are really high risk, where you need to be able to have kind of all of the information available, including being able to see someone and be in the room with someone in order to make sure that someone's able to keep themselves safe. People that have a really hard time focusing on teleservices. So people who have communication needs. So if someone needs a translator, or if someone really struggles with communicating verbally, those patients are going to be better served in a face-to-face setting if that's possible. And there's also different types of group therapies that are very sort of experience-based that really aren't going to translate very well long-term to being over teleservices. So I think that there are some things that people are pretty aware of. We will clearly want to transition to being in person. And I do think that there is going to be kind of a gray area of things that work in telepsychiatry or, by teleservices. And there's a really strong patient preference for that. And I think there's a little bit of kind of uncharted waters in terms of where ultimately that balance is going to end up.
I think to Kathy's point, though, about balance, always been one way or the other, and just moving forward, trying to make sure that everything is included, and we're able, especially you as a provider, to have that flexibility to be able to do both. Right,
and to make sure that the patient's preference is also included in that.
Right.
Because if, for example, if a person really, really is uncomfortable coming into a clinic, and we have people that are really uncomfortable with that, then what I would want is to be able to meet with them using teleservices so that we can still stay connected. But yeah, you're right. We're in this space where it's not going to be just one way or the other, and the environment in which we're providing services is, the landscape has totally changed. And I think it's also an opportunity for us to figure out what is the best balance.
Well, that's exactly my next question, because, CMS and Access have been a little bit more lenient. They've relaxed the rules on billing, on HIPAA.
Yeah.
And so now is a time to kind of look at and challenge some of the ways that we've done business, and we can come up with the research and show that these are effective and cost effective. And we've never really had those opportunities.
Absolutely. And I think that that's one of the things that we've been really interested in our clinic, because we have been interested for a long time in trying to have more teleservices and being able to say, look, now we're going to have all this data we've never had before moving forward in terms of what are the outcomes, what is this experience like for our patients, and then just in terms of things that the insurances would be interested in and the companies are going to be interested in, because that's going to be part of the conversation, whether or not we wish that were the way that it is. And so also seeing that the no-show rate is really low, and seeing that, maybe hospitalizations decrease because people have more ability to access providers. I think will also be really important data moving forward, that because we've never had something on this scale before, we've just never had those numbers before.
Right. Whitney, does CRN do any remote crisis intervention? Has that had to happen because of the situation?
I don't know any specific examples, but if somebody were to call our crisis line, of course, the goal is, and this is in central and northern Arizona, of course, the goal is to stabilize the situation on the phone with our crisis specialist.
Okay.
And we hover around 70% or so stabilization on the phone, which is the good news. If not, if it has to go to that next level of dispatching for a mobile crisis team, they'll do their best to get somebody to where it needs to be, depending on where and how to get them there, because a mobile crisis team is a team of 2, behavioral health technician and a licensed technician. So they'll go, and then they are there to provide that continuum of care, that in coordination for further care for them. And beyond that, when it comes to that conversation, I'm not sure what occurs. It's between them. But sure. We do have mobile crisis teams in northern Arizona and central Arizona. Southern Arizona is managed by a different entity, but the help is there as well.
And they're pretty stocked up with personal protective equipment?
As far as I know.
Okay.
Yes.
Sure.
Doing their best. The beauty of being a crisis line is hopefully many of those calls can be stabilized. Doctor, my fellow panelists, I appreciate what you were talking about. I'm learning quite a bit from my fellow panelists. Thank you for that. But and it's interesting talking about the telemed and things like that, when oftentimes a crisis line is somebody's first go-to, and that's been telephonic for years.
Mm-hmm.
Yeah.
And getting handled. So it's interesting to see from a perspective of crisis, and right off the bat, someone calling a crisis line, 2 a.m., it's a real bad day, right? To perhaps something that's really truly evolved into what your teams are doing in your clinics and in locations. So it's interesting to see how that can work, and I'm learning a ton. Thank you.
I feel like I'm also learning a lot.
So,
I'm happy. I'm very excited to be here.
In Yavapai County, at the very start of the COVID crisis, we saw a dramatic rise in suicides, and we immediately responded as a community with the sheriff department and the health department. Everyone came together, and I know that personally, I just had a suicide in my family directly related to the COVID loss of job. So could you guys comment about what you're seeing is across the state is happening? We're just not hearing much anymore. And we know that it's there, it's insidious, and it's just, it's there. So could you guys maybe make some comments, what's being done, what you're hearing?
You mean to address suicide, Kathy?
Well, the increase in suicides, people are losing their job. What we found in Yavapai County, it was not the COVID itself, it was the loss of job, being home all the time, the social isolation, it's, and I just haven't heard much with the rest of the state. I know we took some very proactive steps to combat this, but I don't know what is happening with the rest of the state.
I'll let you take it first, Doctor.
Yeah, so I can't.
That was good.
Oh,
You're fine.
I'm teasing.
okay.
Oh,
I couldn't hear what you said, so I wasn't sure if you still were asking a question. So I can't speak to what is sort of the full response from Pima County, so in southern Arizona, but I do know that starting in March, we did have an increase in the completed suicide rate in Pima County. And I've also seen kind of a higher sort of workload on our consult teams in the hospitals. And certainly there are a lot of different factors. And I would absolutely agree with you that it's not, most of what we're seeing isn't directly tied to sort of the COVID illness, but sort of all the sequela around that. And one of those things is also the increase in intimate partner violence with people that are, isolated at homes and don't have sort of the resources or other supports that they used to have. So we have published on our psychiatry website an article called "COVID Behind Closed Doors," addressing that. And we've worked on making sort of resources available to people where we can. But it is a really, I don't have a perfect answer about how to handle it because it is such a far-reaching issue. And certainly I've seen it in my own clinical practice, people having a lot of financial issues, people not being able to see family members that are ill. And then in addition to sort of all of the other kind of worldwide stressors that are going on. So ways that I've sort of worked individually with people around that in terms of kind of building resiliency has been around, widening the amount of support that they can muster, putting them in touch with supports, increasing sort of their scope of attention to incorporate other things, and working to establish a sense of meaningfulness in these moments. And so I think that's sort of what we've been seeing here.
It's really tough right now. I know just being a mom and having those limited interactions with other parents at school, I didn't realize how important it was, just especially now with kids being home all the time and me thinking, what am I doing wrong? Why is this so hard? And just having another mom to be like, oh no, it's everybody, So I think that would probably contribute to just exacerbate everything.
Yeah.
I don't know how much it would have to do with the increase in suicide, but I know with the kids, we were already seeing a rise in suicides, and I don't know if that has gotten worse or stayed the same. So if either of you two wanted to address that, I just wanted to mention the kids. And again,
I can chime in a little bit. Kathy, my condolences. I too actually just dealt with that about 3 weeks ago in our family. It's hard. I'm going to struggle through this piece of the conversation. I think for the most part, one thing I do want to stress here is suicide, that type of thing. It tends to be one of the number one reasons why people do call our crisis line. We do our best to get to those folks to stabilize the situation however we can, whether it's through mobile dispatch, 911, you name it, right? Also, I think when we're talking COVID, as COVID being a catalyst or not for somebody taking their own life, what's important is the federal government has taken notice that this is going to be an issue. It's becoming an issue. All sorts of mental health setbacks, if you will, for folks, and why the crisis counseling program, why FEMA said, okay, we're going to grant this. And my emergency management community that's on this webinar today understands in Arizona, it's rare. It is rare that Arizona sees an individual assistance declaration from FEMA. It takes a lot. I can't speak on behalf of my emergency management partners or DEMA where I came from, but I can assure you it takes a lot. And for FEMA to step up and say, this is going to be a problem, we need to at least, if not giving an entire declaration, but give this piece of a declaration and fund this for the states to get ahead of this. Mm-hmm. As I mentioned before, crisis counseling being that first go-to of resilience, prevention, giving this, providing another resource for folks. And that's really kind of how I want to touch on that. So oftentimes people will ask me, how do I know when to call even just the crisis line? Kelly, you said it's hard to get in touch with other parents, or there may be other reasons why someone may need someone to talk to. Maybe it's not the crisis counseling program. Maybe it's not 211. Maybe it is simply crisis line. Oftentimes we tell people, if you don't know if you should be calling, call. Let's let our crisis specialists determine that, whether or not you should be calling, or if someone you know is going through something and you don't know how to handle it, by all means call. Hey, my friend is saying these things or going through this, and I'm not sure how to respond, how to react, how to handle it. Do call. And we have our warn line. I tell audiences all the time, I can't see everyone who's out on YouTube, but raise your hand if you've had a bad day. I think we should all be raising our hands. Our warm line is there for people to simply call and talk to. They are trained peer support specialists. Somebody who's been through something, and for 15 minutes every hour, you can just have someone to talk to and say, hey, I get it. So the biggest thing, the stress, is that these resources are there. And then, doctor, if it ever gets to that point for folks that they start scheduling with you, then I'm glad, then there's someone else even beyond what we can do from a continuum of care, a telephonic system, if you will. So that's really all, just to kind of make a point there, is that resources are available.
And I would just want to kind of support you in what you're saying, that I think the vast majority of the time what we see is people not reaching out. And there's sort of a fear of, is it at that level? Should I be doing that? Maybe I'm bothering someone. And I would say the vast majority of the time it's skewed towards not reaching out. Mm-hmm. And so I'd absolutely support what you're saying about, if you're not sure, then call. And the same is true of our clinic, where we would so much rather hear from you than have you just suffer until the next appointment.
Well, I think one of the issues with the resources is they may be there, but a majority of people don't know about them unless they're somehow linked into the community. So I think that's a challenge for all of us, is how do we get that information to the community, that, you don't have to go through this long process, with intake and referrals just to tell someone you're having a bad day. Because I think right now, people just want relief, just a little bit of relief, however that comes. And a simple phone call is great, but a call to a referral to an intake, it's not what they need. So getting that information out there is really important. What do either of you or any of you have as far as recommendations on getting the information out there?
Everything you can imagine, from social media. We have someone on staff who handles that specifically. Our internet, our websites, everything else. Like I mentioned earlier in my introduction, one of my roles is I sit on various coalitions throughout the state. The Yavapai Coalition, Pinal County Coalition, all for mental health and substance use.
I know you.
Is that?
We all know each other by
yes.
This is how. So it's always encouraging to know. Now you've been embedding ourselves among all these other organizations, because we all know in the emergency management arena, we look at things from that whole community perspective. One organization can do it all. We know this. So it's a matter of, okay, if I can have 5 minutes at a coalition meeting, hey, just a reminder, we're here. 211 is 24/7 now. Just those little tidbits of information, putting out into those really uniquely community enhanced organizations and coalitions that are so unique to those counties individually. That's going to be key. To just keep spreading the word. We'll do the rest by social media and everything, but we're going to have to rely on some other folks too to get that out there as well.
I think
I have a comment. Oh, go ahead. No, go.
I was just going to say that, kind of coming from that side of where people are having that full intake and everything, we certainly do outreach into the community in terms of like being at kind of events in Tucson to make sure people know what we offer, because often people think of psychiatry as like we just do 15-minute management appointments and don't realize that we also do integrative psychiatry and perinatal psychiatry and group therapy and therapy without medications. But we also, I would say, do a pretty good job of getting the word out about the crisis line and the warm line as well.
Thank you.
So all of our patients that come through our clinic, we provide them with the crisis line and warm line numbers. All of our social workers in the emergency department use that, and so does the crisis response center that we have here too.
Thank you for bringing that up. Shameless plug for CRN. I have these wallet-sized cards that I have an abundance of and can have sent out to anyone who needs it at their front desk.
Or send us some.
You need more? They're English and Spanish. And I have them for Northern Arizona as well. It's funny, Doctor, you brought up events, and part of my role at CRN is community outreach. Well, guess what happened since March? There are no events. Mm-hmm. They are now starting to change and turn over and try to create things virtually. It's not the same as having a table at community members coming up to you and talking to you and finding what does all this mean and actually grabbing something. I got to tell you, people love to touch and feel. They love having something, and these are great. They're discreet. You keep it in your wallet. I keep one in my car at all times in case, heaven forbid, I run into somebody who may be saying something and I may be like, here, just make a phone call, whatever. But it's true. People will value having things. So if anyone in the audience, and Sarah Ann, if my contact information, if someone wants a stack of these to have at their offices or wherever they are, I also have wallet-sized cards for 211 as well, with a QR code on it that people can put their phones and hover their phones right over it to get to the website. These things are available, and with lack of these community events, it's tough to get these things out there. So we're all struggling in different ways of managing information flow right now, but we're doing our best.
Hey,
I had a question as far as emergency management. As far as emergency management, I went through a lot of that training. There's different stages, okay? And kind of one of the end stages is the mop up and planning for that. So you kind of touched on this, but right now we're working with people to be more resilient and to deal with the crisis at hand. But we've also got a lot of PTSD, a lot of stuff that's developing, and we as a community are going to have to come together to take care of that after the demic. We've got, young people that went out, came home, exposed their parents, and now, their parents died. And so can you comment about this kind of last step, this mop-up step that we're going to have to deal with as a state?
I can't speak on behalf of emergency management per se. I will leave that to them. I like how you say mop up. It takes me back to the fire day, right? Demob for this, down, coming back, recovering, right? I don't have much to comment on that, honestly. I think have a conversation with your county emergency management office. You have a very robust community organizations active in disaster coalition in Yavapai County. I think it would be good to touch base with them. Kathy, again, when you and I talk offline, I have an abundance of contacts I can give you to start embedding yourself in some of those other areas and really talking about that at that local level, because as we know best with emergency management and disasters, they begin and end at the local level. So I would encourage creating and building that relationship with your local Yavapai County COAD and emergency management and getting a feel for what that might look like in your communities.
Hi, I have a question for the people over in Yavapai County. We hear about the nursing homes, and to protect everybody, they shut down the Pioneer Home. As soon as this all broke out, no one was allowed to leave anymore, no family visitors. And so a lot of the people that live there are still able to walk and don't necessarily need assistance with bathing or anything. So since late February, they are in their rooms, someone delivers a plate to them, knocks on the door and delivers their food. They have no face-to-face contact with anybody since February. And I didn't know if someone in Yavapai County could possibly reach out to them and maybe set up some ideas for things they can do to improve the quality of life for the residents that are there, because they are getting rather desperate, and this is not ending anytime soon. They're doing it to keep them safe, but they also may be causing a lot of damage.
Hi, this is Sarah Ann. I definitely want our panelists to answer that question for you. I just want to explain that we are having members of the public watch on YouTube now, but we still have a few that are signed in through Zoom. And so I definitely want to continue to have that question go through. But if you don't mind emailing me any further questions, and we'll go through our panelists. And my email is Sarah, S-A-R-A, @azsilc.org, and that's also on the YouTube. So please go ahead, Whitney.
Oh, no, I would actually defer that question to Kathy in Yavapai County. I'm not from the county. I can't speak to that.
Thank you. I think we need to be very careful. I have friends that are in the nursing home. They are coming and going, which concerns me. They come and go back to eat, or they go back and forth to spend the night. So if that person would like to give me a call, I'd be glad to talk with them. I think the nursing home is doing the very best they can at this point. Sarah, did you want me to wrap this up?
We still got a few minutes if you did have additional questions. We don't have any from the YouTube, but I know I personally had one for Whitney before you did wrap it up. So I want to give it to you first, so in case you had a question. Okay, well, I'll shoot turn my video on so you can see. Whitney, when I was getting ready for this, I noticed you were in another webinar recently, and that was about an exercise we were part of together, and that was the National Mass Care exercise in 2018. And they were asking like what we had learned that specifically helped with students. And ready for this, I didn't get to hear it, and I was hoping that you might elaborate a little bit upon that webinar and what notes you took out of that exercise that apply now.
Well, when was that webinar? I actually don't recall being on that. Was that?
Oh, it might have been old. I'll send it to you.
Good, yeah.
It was at ASU.
Wow. Yes, and I feel old since you brought up the National Mass Care exercise from 2018. That was the undertaking. Say again what your actual question is, Sarah Ann.
Oh, absolutely. The webinar itself was about like if we learned any lessons that applied to students. And I know for myself, that was my first exercise. So to me, like the big standout things I learned were all about disability. So I didn't have a big takeaway for students. And I was wondering, what your takeaways were in general, if it was for students or if you had anything else that, you learned from that we applied now.
I think we can speak to that in general. Yes, for those who don't know, in 2018, we conducted a massive national mass care exercise here in Arizona. Federally, they tap a state to host it every year, and the state is at liberty to decide what the scenario is. And our scenario was a massive earthquake taking place in California, which was sending hundreds of thousands of people to Arizona because they had nowhere else to go, and we had to very quickly learn how to plan for that and what do we do for them when they all get here. It was definitely a learning opportunity because of from a mass care perspective, right? Sheltering, feeding, all things at hand when you're looking at mass care, and we incorporated all different entities. When I spoke before, the whole community concept, yes, ASU was involved, schools were involved, private sector was involved. What does all this look like? Hotels, tourism, you've got all these people coming in. And, I think what we learn from that and we apply to this is the more partners, the better. The more we learn from each other. And I think, and in terms of when you look at a pandemic, or you look at an earthquake that's sending hundreds of thousands of people to the neighboring state, when you look at wildfire, Yavapai County, of course, it's a bad time of year in Arizona. We've seen many fires. Now we're in monsoon season. We're looking at post-fire flooding now. And when you look at all that, we really look at these things as all hazard. Whether it's a pandemic, whether it's a fire, it requires partnerships and it requires planning and it requires what we're doing here today. Today, even though we're in the midst of a pandemic, you can always take a webinar like today and apply something you learn from it and continue to plan and use it. And suffice it to say, for any audience member, I can be of service to you. Call on me if you have a community organization or someone or a group of folks that you think would benefit from learning about who CRN is, what we do, how to access our resources. I have a whole presentation I can give, and I'm happy to do it virtually because this is our platform. This is who we are now. This is seeing my dining room. So just looking at it that way, Sarah, I think that's a really great question, and thank you for bringing it up, because I think ultimately with what we're doing right here today and talking, clearly we've come full circle in knowing the more people involved, the better.
Thank you. And I just wanted to get that in there, so I'm going to let Kathy finish it off.
Oh, I had a question before we wrap up. Hang on, Kathy. I wanted to ask both panelists if you're doing any outreach specifically with the schools, and if you are, what is it, and if not, how can we get that going?
I'll touch on that really quickly. First, you want to doctor, then you want to wrap it up? Schools call our crisis line quite frequently, but they obviously haven't been. That's kind of been quiet on our forefront. We actually do have a really, really good relationship. I'll give a plug for a great partner, Teen Lifeline. Is actually, I always want to mention them. They are a great partner with schools, with teens, with that audience. Oftentimes I get materials to schools. We're invited into their events to reach out to, so administrators and students know who we are. Oftentimes I will defer to Teen Lifeline because they're uniquely trained for that audience. Just so people understand, Teen Lifeline does have a set number of hours. If somebody calls that line after hours, it will get automatically routed to our crisis line. So no one's missing an answer. So just want to be sure to touch base with that. But community colleges, all different levels. Yeah, we will make sure they understand what our resources are, how to access them, especially that community college level. When you start looking at some of it becoming out of those teenage years into those adult years. So we do our best to outreach who we can and whatnot. And as far as schools and other entities are concerned, we do provide different trainings like mental health first aid training, things like that, where people will also providing to as a resource. Oh, my esteemed fellow panelists to touch base on that too.
Yeah, well, so in terms of reaching out directly to schools as a adult outpatient clinic, we don't have a lot of contact with sort of younger school age kids, but we do have a child adolescent psychiatric clinic that's in the same building as us. And I actually don't know what they're doing, but this is a really good prompt for me to reach out and see.
Well, I'm just, if in my school district, there are 30,000 families. So it's kind of like a nice hub to give out information.
Yeah.
And especially with the pandemic, there's all kinds of new stressors for families.
Yeah.
So, I just wanted to throw that out there because I would love for more resources, school district and the schools for families. Not necessarily just for crisis, but just, just in general, like it's okay to be a little nutty right now.
And I think also just in general, so I also do perinatal psychiatry.
Mm-hmm.
So working with moms is a part of my practice. And certainly I've seen sort of the impact of the change in the school schedule on sort of the family dynamic and what's practical and what's realistic and feasible and the pressures associated with that. So, and I think it's also sort of this microcosm of pressures that already exist, and always exist. But now we're just seeing it sort of all bottlenecked into these, few months, into these really intense situations. And I think for mental health, such a sort of highlight on the things that are missing and that we could use. And absolutely we could use consistent resources for families and for kids and for parents.
And I think that CCP, the crisis counseling program that's just been implemented and launched, is a great outlet for anyone in the family. Give it 211 a call. You want to reach out through the crisis counseling program, resiliencearizona.org. That's a great place for people to go, especially since what they may be feeling is probably COVID related, or COVID was a catalyst for that. So, it's okay to not be okay.
Exactly. I think that might be all that I had. I could probably ask questions for the next 2 hours, but I won't. I'm going to turn it over to you, Miss Kathy.
Well, I think we're we're at the end. I'll just wrap it up very quickly.
Okay.
I think that the COVID experience has really made it very apparent the health disparities in our community. And I feel from this conversation, I feel very good. The panelists have done an excellent job. It sounds like we're working from the local, the state to the federal level and communicating. We have some wonderful experts. And I think this situation, I think we all see the COVID experience is opening up many possibilities for us to make changes within the healthcare system. I think providers are optimistic that we can make these changes through research and documenting what we're doing now to meet the expectations and the needs of our community. One thing that I would like to say that we really haven't touched on is strong state leadership. We have not received that. For instance, but the peer runs and a lot of providers did not get guidelines as to when they should be closing down, when they can offer transportation for people. So this left many people in our community, the peer runs, the providers, kind of in limbo, and peers really afraid. And so there was quite a period of time there that we operated without any guidance. So I think the end thing that I have to say is thank you guys so much. You were wonderful, and I feel better than I have in weeks after hearing you. So thank you. Sarah?
Thank you everyone for attending today. Thank you Kelly and Kathy for being our moderators, and Whitney and Dr. Emmerich for coming today. And we have been live streaming, so this will be available on YouTube, but I'll also be making an edited version, and we'll have that out soon. So thank you guys. Bye.
Thank you for having us.
Thanks.
Bye-bye.